Good morning, everyone. The study what we are going to present is on antibiotic resistance, showing in MSF acute trauma hospital in Aden between January 2018 and June 2021 in Yemen. After more than 7 years of war that erupted in Yemen, today the country is facing a dire public health crisis. The healthcare system has collapsed and almost half of the healthcare facilities are dysfunctional. The functioning healthcare facilities are often unoccupied and struggle to find medical staff needed for many have left in the countries. The conflict that has resulted in thousands of internally displaced people, mainly living in tented settlements. And every year, hundreds of civilians are reported as injured, leaving a young population and disabilities and lack of proper medical care. One of the main cities in Yemen and South Yemen where many people living in neighboring districts seek medical care is Aden city. And this where MSF hospitals exist. For instance, in 2012, MSF started an acute trauma hospital to treat a primarily wounded patient, war-wounded patients. The hospital has been gradually increasing in its capacity and today is functioning with level 3 ICU, 8 inpatient departments, including 2 isolation units. The hospital has also OPD to follow-up consultation. There is also an occupied general and microbiology laboratory. At the hospital, MSF has implemented an antibiotic stewardship program. And in 2018, the hospital adapted their empirical antibiotic treatment based on 1-year review of microbiology hospital data. As a result, the review of many usual first-line antibiotics was replaced by a second and third-line antibiotics, considering the high level of antimicrobial resistance seen among the patients treated that year. And here I'm giving you a brief overview of flow of the patient, those suspected with infection, based on MSF protocols. So if the patient show any signs of infection or clear evidence of infection, they might send it to a surgical treatment, which might include the tissue and bone sampling, and then a therapeutic antibiotics plan was set in place. Some of these patients are stable enough to wait the pending results and then treating them definitively on the antimicrobial sensitivity profile in their results. And some of them had a systemic symptoms and they are not stable enough to wait. An empirical treatment is mandating pending the microbiology result. The 2018 guidelines was very useful in developing hospital-specific empiric treatment using the hospital antibiogram derived from microbiology data. But there was no link or direct link between the patient data with the microbiology data in order to correlate the different types of infection and clinical presentation to the bacterial isolate and their resistance pattern. The study main objectives were to describe the demographics and clinical characteristics of these patients in relation to their infection diagnosis, based on determining the most common pathogens that were responsible for these infections, their resistance patterns, and susceptibility profiles. Therefore, we designed a retrospective cross-sectional study, including all patients who were admitted in MSF acute surgical trauma hospital in Aden and treated with antibiotics according to their diagnosis between January 2018 and June 2021. Here, a definition that I would like to present, which is multi-drug resistance, and multi-drug resistance is defined based on our hospital as a lack of susceptibility to at least one antibiotics agent in 3 or more chemical family or classes of antibiotics. According to this preliminary finding of our study, we had 481 patients in our study. The majority were males and youngs with an average age 28 years old. The main cause of admission was a violence related primarily with the gunshot wounds. The patient was multiple site injury, where abdomen and the lower limb injuries were the most frequent. Accordingly, these patients were presented with different types of infection during their hospitalization and were treated for 591 infections accordingly. A combination of all infections diagnoses that occurred during hospitalization was analyzed, including infectious presumably presented at admissions and other are presumably nosocomial. Accordingly, out of 591 infections, the most common were the soft skin and soft tissue infections, followed by osteomyelitis and intra-abdominal infections. Out of these infections, 59% was the most common. Out of these infections, 59% were multi-drug resistant, and 1/5 of it were presented or complicated with secondary bloodstream infection. Among these infections were raised within 48 hours of admission. More than half of this cohort diagnosed with multi-drug resistance infections. Our analysis also showed that those presented with the gunshot and penetrating wounds were more likely to have multi-drug resistance infection compared to patients with the type of injuries. Looking to the bacteria, the main bacteria that were isolated from these infections was Staphylococcus aureus and Escherichia coli, while E. coli was the most presented in intra-abdominal and skin and soft tissue infection, Staphylococcus aureus taking the lead and isolated from the cases with wound infection or osteomyelitis. Generally, we saw a high rate of resistance among the most prevalent bacteria. For instance, MRSA, methicillin-resistant Staphylococcus aureus, exceeding 70% among the Staphylococcus aureus cohort. And Escherichia coli producing extended spectrum beta-lactamase was up to 83%. The majority of Acinetobacter showed a high level of carbapenem resistance, which is more challenging. A closer look to the results of the antibiotic susceptibility test revealed a wide range of susceptibility pattern across the different bacterial isolate. For example, E. coli show a very low susceptibility to aminopenicillins and cephalosporins as is a result of a high extended spectrum beta-lactamase producing isolates. Similarly, we have so low susceptibility to other groups like cotrimoxazole and fluoroquinolones like ciprofloxacin and levofloxacin as an example, which are used as a main option for oral antibiotic treatment for these bugs. And this could be a challenging as lacking the oral option, especially for wound infection, which might had a duration of treatment reach up to 12 weeks, is known to increase the length of hospitalization due to IV administration, and this is add a burden to the hospital, especially in the lower context or lower resource settings. However, the carbapenems, in addition to specifically amicacins from the aminoglycoside group, seems to have high susceptible and effective against these ESBL-producing organisms. Regarding the Staphylococcus aureus, we have low susceptibility level to cefoxitin, which is representative of the high MRSA percentage, but high susceptibility to other antibiotics, including vancomycin. For the Pseudomonas, level of susceptibility were good overall, unlike Acinetobacter baumannii that shows a very low susceptibility to all antibiotics, with the exception of colistin, which is not so favorable due to its high side risk factor or high side effect risk factors. We acknowledge that our retrospective analysis has its methodological limitation and insufficient data. However, we went back to the patient file to complete all the missing information, and we also linked the microbiology hospital data, which is WHONET, with the patient clinical data. This allowed us to associate the bacterial and resistance pattern with the clinical characteristics. As a summary, the study showed a high levels of multi-drug resistance infections among patients who are most frequently presented with penetrating gunshot wounds. Around half of the patients presented with the signs of infection within the first 2 days after admission and MDR infection. This raises the question around the prevalence of antibiotic resistance among the community, where more understanding of community-related infections would be needed to be in the future. Our current antibiotic treatment was in line with the resistance profile seen in our study cohort. Our current oral options for a patient infected with Staphylococcus aureus remain effective. However, our challenge remains with E. coli and other organisms like E. coli infections, as it shows low susceptibility to oral antibiotics. Our study findings can also inform the clinician and the local health authority in Aden who are treating similar type of patients to help providing effective antibiotic therapy based on the current resistant profile on most prevalent infections. This study has been implemented by the effort of the study team, to whom I would like to express and extend my sincere thanks and appreciation. Thank you very much.